everyone. I welcome you all to the DBMCI channel. I'm myself Dr. Rajesh Gubba. I'm the general medicine educator and a cardiologist. So, as a part of the daily discussion on the clinical ECG, we have come on to the discussion of the fourth clinical ECG today. So, today's ECG is a very interesting ECG, and I'll just show you how the clinical presentation of the patient was in the emergency department, and we have taken an ECG, we have injected a drug, and the ECG immediately reverted. We have waited the patient for 1 day only in the hospital, and on the next day we have sent the patient comfortably with a normal ECG. So what is that entire story? I'll discuss now. So before going ahead with the session, let me tell you that I am discussing the ECG in detail on 29th of January. So in this session, I'll be discussing the ECG from the basics to the advanced level. And this session will be useful for 3rd, 4th MBBS students, interns, post-interns, junior and senior registrars, and as well as the postgraduates. And followed by this session, I'll be also giving you, or I'll be providing you the PDF of the session, what we have done. And the session is going to be from 9 a.m. to 9 p.m. on 29th of January on eGurukul app. Let me tell you, after attending this session, you will be able to handle all the emergency clinical scenarios. You will be able to handle the MI. You will be able to handle the cardiac tamponade. You will be able to handle arrhythmias. You will be able to handle the sudden cardiac deaths. So I assure you and I challenge that you will become thorough in these emergency clinical scenarios after attending this particular session. So to get subscribed to this particular session, just click on the link which has been given in the description. And the session is going to be on 29th of January. So going ahead with the present session. So the clinical presentation of the patient is like that. Very simple, 29-year-old female. Right, no significant past history. She came to the emergency department with 2 hours of palpitations and mild chest pressure and general body weakness. She denied shortness of breath, no nausea, no sweating, and there is no leg swelling. And she denied any drug abuse as well. No alcohol, no tobacco, right? And neither she is a pregnant. And temperature, she is afebrile, but tachycardia was there, heart rate of 142 beats per minute, blood pressure of 123/70, respiratory rate 20 breaths per minute, oxygen saturation of 100% on room air, right? And cardiovascular examination showed tachycardia was there, but rhythm was regular, no rub, no murmur, no gallops. Respiratory system examination, abdominal examination, extremities, and as well as neurological examination was absolutely normal. So the patient presented with history of palpitations. No other significant past history. So immediately what we have done an ECG. So this was the ECG of the 26-year female patient. So just see the ECG, and I have given you the options also: right bundle branch block, left bundle branch block, fascicular VT, polymorphic VT. So what is that you are suspecting in this patient? So if anyone has thought of the answer, let me tell you, the correct clinical diagnosis of this ECG is the fascicular VT. So the patient was having the fascicular VT. So the next question in your mind will be, sir, how to recognize the fascicular VT? So there are three or four changes which are very important thing that you will be able to pick up the fascicular VT. First and foremost, very important, left axis deviation. Right, first and foremost, there will be left axis deviation. So you can make out you have S wave and as well as the R wave. So S wave in lead 1 and R wave, that is positive R wave in lead 2, right? So that tells you it's a left axis deviation. But in detail about the axis, I'll be discussing on 29th of January when I'm doing a session. And this patient, apart from left axis deviation, the individual is having left anterior fascicular block, right? Left anterior fascicular block. So how can you make out that the individual is having left anterior fascicular block? Number 1 is your left axis deviation. And second is, you take the presence of the RS complexes. You have a small R wave and deep S wave, where in the inferior leads. So in lead 2, 3 AVF, you have the presence of the RS complexes. And apart from that, if you observe the duration of the R wave in AVL, it is more than 45 milliseconds. So these are the points in favor of left anterior fascicular block. Left axis deviation, RS complexes in lead 2-3 AVF, duration of the R wave is more than 45 milliseconds in the AVL. Right, ideally there should be also presence of the QR complexes. That means you should have a Q wave and tall R wave in one AVL, but we don't have that, but still we can consider that there is a left anterior fascicular block in this patient. So that is one point in favor of fascicular VT. Right. Second point, the ECG should have RBBB pattern. What is RBBB pattern? There should be a wide QRS complex. Followed by that, you should have RR dash pattern in V1 or dominant R wave in V1. And along with that, you should have a deep S wave. And that too, this particular S wave should be a wide S wave in V6. So this is what is your RBBB pattern. That is the second change. And the third important change of the fascicular VT is absent P wave. See, when you're using the word ventricular tachycardia, the impulses what you have is the ventricular impulses. You will not have a P wave at all. And wide QRS complexes. So these three changes to tell it as fascicular VT. Number one, left anterior fascicular block should be there, in which there is left axis deviation. Number two, RBBB pattern should be there. Number three, absent P wave. So these are the, and next thing is tachycardia. Tachycardia is already there in this individual. Tachycardia is already there in this individual. So if you observe the rate, it is nearly around 146 per minute. So these are the changes of the fascicular VT. So now after diagnosing that it is a patient with the fascicular VT, what is the next step? The next step is how to manage this patient. Let me tell you what we have done to this particular patient. What we have done is we have given 10 milligram of the diltiazem. After giving 10 milligram of diltiazem, there was slowing of the heart rate within the individual, and ECG was obtained, and the ECG showed the appearance of the P wave. You can see that here. You have a P wave and then the QRS complexes. So PQRS, that means you have a independent QRS complex. It is not that only QRS complex. You have a P wave and as well as independent QRS complex. That means the fascicular VT is slowly getting converted into the sinus rhythm. So what we have done is, so diagnosis is idiopathic fascicular VT. We don't know what exactly is the cause. Why? Because there was no pre-existing disorder in the individual and no drug abuse, no coronary artery disease. So what we have done is, after cardioversion, we also have taken an echo. Echocardiogram showed the normal ejection fraction, 55% was the ejection fraction of the patient. And we have admitted the patient in the telemetry unit. And what is telemetry unit? It is the place where the cardiologist will observe the heart rate for an extended period of time. So we have admitted the patient in the telemetry unit and we have started the patient on flecainide and as well as metoprolol orally. But there was no abnormality in the rhythm in the telemetry observation. But the patient was discharged from the hospital in a normal sinus rhythm. So this was the rhythm, right? Normal sinus rhythm at the time of discharge. So this is the clinical scenario of a fascicular VT. So what is the take home message now? The take home message is that in patients with the fascicular VT, you have to remember three important changes. Number one, they'll have left anterior fascicular block, wherein you can make out there is left axis deviation. Number two, there will be RBBB pattern. Number three, there is no P wave. And what are the drugs that you can give? You can give either calcium channel blockers or beta blockers can be given. Actually, we have given adenosine to the patient, right? But the patient did not respond. The ventricular rate did not reduce. So later, like what we have done is we have given the calcium channel blockers, that is diltiazem, we have given 10 milligrams. After that, the ventricular rate has come down to normal, and then we have discharged the patient on flecainide and as well as metoprolol, and this was the normal sinus rhythm with which the patient got discharged. And we have asked the patient to come back for the follow-up after a week or two. right? So we are just waiting her for the follow-up. This was the recent case like what we have come across in the hospital. So this is the clinical case scenario of today. So thank you very much. See you again in the next clinical session, that is tomorrow. So anyone who want to get a detailed knowledge of the ECG, just get subscribed to the course which I am doing on 29th of January on eGurukul app. So for getting subscribed, you have to click on the link which is given in the description below. Thank you very much. See you tomorrow again.